So I'm going to introduce myself. I'm Bhaskar Dasgupta. I'm a rheumatologist at Mid and South Essex University Hospital at Southend. And I'm going to talk to you today about ultrasound in a fast-track clinic setting in GCA. So the main aspect of my talk is really going to be divided into two different things. One is we are going to talk about the probability-based algorithm using ultrasound and additional tests in the diagnosis of suspected GCA in a fast-track clinic. And then I'm going to talk about how we can actually use quantitative ultrasound to make assessments, not just of diagnosis, but really of monitoring and of disease prognosis. This is work in construction at the moment, but nevertheless, it's an exciting area that we need to, as GCA enthusiasts, get into. So first, the probability-based algorithm. The big problem with GCA is that, of course, you need to have a fast-track clinic to try and avoid ischemic site loss. And to do that, really, you need to be able to see these patients very quickly, the suspected GCA referrals. The problem, of course, is that GCA is actually a very protein disease. It has multiple manifestations, and therefore you're bound to be referred patients who do not have GCA or have one of the GCA mimics, and then you will have to then disentangle from this actually which patients actually have GCA. So we have to triage the patients, otherwise the fast-track clinic is going to get overwhelmed. So what we do at the moment at Southend is we have developed a GCA probability score, and this has been published, and it essentially is based on giving different weightage, 0, 1, 2, 3 positively, to demographic factors, to the mode of onset of the disease, to laboratory levels of CRP, to symptoms, to signs, and most importantly, and this is the most, I think, the major contribution of this score, is we give negative weightage to patients who may have alternative diagnoses. So, with this probability score, which has been published, we can actually build up 3 categories of disease: patients who have low probability for GCA, patients who have intermediate probability for GCA, and patients who have high probability for GCA. So low is less than 9, a score of less than 9. An intermediate score is between 9 and 12, and anything above 12 is high. So how does this algorithm work? So, for example, if you take the patients where the probability score tells you that they have low probability for GCA, and then you do ultrasound. And so if you get an ultrasound negative in low probability GCA, you don't have to do anything, and you essentially discharge the patient. On the other hand, if the patient actually has a positive ultrasound, and you may ask what a positive ultrasound means, whether it is a limited abnormality or a generalized problem. Generally, in low probability, we saw 3 patients who had a positive ultrasound, and these patients we then worked up, including temporal artery biopsies, without actually treating them as GCA. And in fact, actually, these biopsies came back as negative, And the positive ultrasound in low probability makes them GCA uncertain category. And then we did temporal artery biopsies, and they came back as negative. So we said, does not suggest GCA. Now you go to the other end of the spectrum. For example, you take a patient, an elderly patient, an acute onset with visual symptoms, high CRP, and that patient really comes into the high probability group, and then you do an ultrasound. And if the ultrasound comes back as positive, you don't need to do anything else. You just treat that patient as GCA, and you monitor the patient as GCA. On the other hand, sometimes we found that the ultrasound actually came back as negative. And in these situations, we generally, what we do is we treat as GCA, but we do additional tests. So you may wish to start them on steroids if you were concerned about ischemia, etc. But at the same time, you do additional tests. And these additional tests may be temporal artery biopsy, other forms of imaging. PET CT is more difficult if you've got high dose steroids on board. And these additional tests may actually be looking for an alternative diagnosis as well. So you either treat as GCA or as treat as GCA, but you do additional tests. And in the intermediate category, of course, if the ultrasound comes back as positive, you may still want to do an additional test because it's in the intermediate category. And we did that. And in our experience, the ones who had positive tests in the intermediate category, they came back as positive for GCA with their additional tests. So ultimately, what you get is this, from these 4 diagnostic categories: GCA unlikely, GCA uncertain, treat as GCA doing additional tests and clinical evaluation, or treat as GCA. You ultimately come up with only 2 categories: does not suggest GCA or does suggest GCA. So, we have, in the paper that we published last year, we have actually given all the details of what the different investigations were that we did to confirm or exclude the diagnoses in the intermediate category or in the high category. And it's interesting that in the high category, sometimes other conditions came up which are probably more serious than GCA. And so we had to do additional specific tests and to make that diagnosis. For example, there was a patient who was referred to me for tocilizumab, a man with a 60-year-old man who had raised inflammatory markers, jaw and tongue pain. And he responded a little bit to steroids, but really the big problem was his tongue pain, and his ultrasound was completely normal. And then we actually did an MRI of his tongue, and that showed up the cancer in the posterior third of the tongue. So this is how the algorithm works, and essentially, we have found that actually using the algorithm to do the right test, it increases the sensitivity and specificity of ultrasound. And this is now the algorithm that we use in our clinic. So you take the history, the examination, and the CRP levels, and you build the probability score, and that categorizes into 3 different categories. You do the ultrasound, and from the ultrasound, you get the 4 diagnostic categories: that GCA is unlikely, GCA is uncertain, GCA should be treated, but do additional tests, and the 4th, a very clear-cut GCA, where you just treat as GCA. And it is in the uncertain category, or treat as GCA with additional tests. That's where the pendulum may swing back and forth and will tell you whether the patient has or does not have GCA. So this is the way that our probability algorithm works in the fast track clinic. Now we look at the quantitative ultrasound, and it's interesting that actually the first paper, the first presentation we made on ultrasonographic halo score was in 2015 at the EULAR, when Christian was still working at Southend on the ACR EULAR PMR guidelines. And we at that time came up with a semi-quantitative score, but now we think that we actually have a quantitative score which has been published and certainly shows association with diagnostic accuracy and with ocular ischemia. So I now start calling the ultrasound in GCA, we should call it the 8-vessel scan. So, and you can do 10-vessel scans, for example, if you want to use facials, or a 12-vessel scan if you want to use occipitals. But your 8-vessel scan is your basic minimum. And here you can see the 8-vessel scan. So you have the common temporal, you have the parietal, the frontal, and so that makes 3 segments on either side. So 6 on both sides, and then you have the 2 axillary arteries. And we have published how we can grade these into.
Yeah. You would have 2 minutes.
Okay.
You still have 2 minutes.
Okay. So and we have used to build up the halo score, what we have then done is shown that actually it is very correlates with inflammatory markers and ocular ischemia. Patients with ocular ischemia have high halo scores, and we looked at the biopsy findings. And this is a TABL study, and in fact, they have intimal hyperplasia, patients with high halo score. So we have shown that imaging and pathology go together. And now we are actually doing the HAS GCA study, looking at a prospective study of patients with GCA 1 year, and we look at the halo score, how it changes, and it is an international study. We have sites in Italy, Spain, in Netherlands, and of course in the UK. And essentially, it's very dramatic. First of all, the probability score works in picking up GCA. The clinical features go hand in hand, with high halo scores, things like jaw claudication, tongue claudication, polymyalgic, less with headaches. And we have shown actually that both the temporal artery halo score, the axillary artery halo score, and the total halo score, they show significant changes. And at the moment, we are now trying to disentangle which patients show a good response, which patients have a static response, which patients have elevation of the halo score. And this is work in progress, and we've shown actually the halo score is very good diagnostically in picking up GCA from controls. So I think I'm going to stop there, Christian, and thank you very much for giving me the opportunity. And here are my acknowledgments, all the research fellows, in particular Dr. Olwen Sebastian and Niels van der Gist, who came from Groningen and worked at Southend, and Alessandro Tomaleri, who came from Milan and is now a center in Italy as well. So, and all, of course, all the patients. So this is work in progress. We hope to get it into publication in the next year or so. Thank you very much.
know we are all in favor of imaging, and I think also the majority of participants are very in favor of imaging, but nevertheless, we would like to challenge you a little bit. And before I start with my first question, I would remind the participants to write their questions on the chat or to raise their hands and to ask. So there's Eugen, who is making some movements in the background, so it's a bit confusing me, but now I'm back on focus. So we have more than 100 participants. That's really a fantastic achievement. So please ask your questions. And in the meantime, I would like to start. Bhaskar, you showed us the different probabilities, and maybe you could also remind the people what are the cutoffs that you established. But my question would be, when you have this high probability setting, why would you need ultrasound to confirm GCA? Would it not be enough to use the response to steroids as a confirmatory test?
Well, I'll take your second question, very easy. Yes, in our GCA study, we are actually showing that the probability score is very, very good at excluding GCA. So the low probability category in our original study had 0% of GCA, and in our GCA study, it's still showing a 0%. So I think you're right. There are, as you will see in the paper that we published, there were many patients in the low category where we did not do ultrasound. That's and in some of the high probability as well, where evaluation showed that they had something else which required rapid treatment, we actually then didn't do the ultrasound. But you're quite right. In low probability category, you do not need an ultrasound. You do not need a visit to the fast track plan. So in terms of the reliability, I think that's something that we need to do. So I think we need to train investigators. We give them cases, and then we try and get them to mark what the probability is. The big problem, Christian, is that when people do the probability scoring, they forget the alternative diagnoses. So we have to carefully look for all the alternative diagnoses: infection, cancer, head and neck pathology, systemic rheumatological disease, or something else. And that is where there is variability, because people are not aware that alternative pathologies give them a negative mark. So I think that would be something very useful to do.
Absolutely, and we will hear about the mimickers in the next talk. But Bhaskar, could you remind us quickly about the 3 cutoffs that you have established? So what is the score for low and intermediate and high probability?
Well, we have less than 9, 9 to 12, and above 12. And in fact, so what we have is, and there are now studies from Scotland actually who are using this as a diagnostic criterion. So almost you can use the probability score as a diagnostic criteria. The big problem is that in an ischemic disease, you can't have very complex classification criteria. You need something to diagnose quickly, and this probability score actually does that. And I know Anna Chichumska in Lanarkshire in Scotland is using a probability score of 13 to decide which patients should get steroids.
Okay. Great. Christina, I think we have some questions out in the chat.
Yeah, we have now a couple of questions in the chat. And the first question was, Bhaskar, how long does it take you to evaluate the vessels by the halo score?
15 minutes. So the 8-vessel scan. So the big problem, Christina, is I work in the national health. So, they won't allow us to scan for hours and hours. But average is about 15, maybe 20 minutes. And I would say that 20 minutes, you can actually get a very decent 8-vessel scan, and sometimes the facials as well. So it's, it's all a matter of training. So if you have a and we have a Excel spreadsheet where we record it, and then it populates the Halo score automatically. So that's what we are doing in the Gca study. So it's fairly timely. It doesn't take that much time.
I think we have the time for one other question.
The other question was, what are the weaknesses of the Halo score? Pascal, can you extend a little bit on that question, please?
Yes, I think that's very important, and that's we need to explore that. So it may be machine dependent. Ultrasound is machine dependent, maybe operator dependency. The interesting thing, Christina, is that we, after a long time, the first hands-on ultrasound workshop last month at Southend, and it was confined only to UK delegates because of travel problems. Next year, we want to hold a big one. But on Sunday, end of the workshop, we did a reliability exercise with 6 ultrasonographers. And Dr. Sebastian, who is leading on this study, he's analyzing the data, but it really looks very good, actually, the patient-based reliability exercise for the Halo score. But it needs training. I think the important thing is, Christina, that people, even sonographers, need to be trained in looking for the, how do you document the Halo score.
Yeah. Many thanks, Pascal, for all your extension and also the very good discussion. But there is one more question from our experts. Please, Wolfgang.
Wolfgang, it goes on costs of your presentation time.
Of course.
Okay, just one question. Great to see you again, Pascal. How do you recruit patients for your fast track clinic? You said you are a little bit overwhelmed of patients, and so do I. We get a lot. On the other hand, I'm always a little bit scared to tell doctors not to send any patients. So actually, I see all the patients. Do you have any algorithm where you say, no, your patient is not allowed? So we have just one inclusion criterion, which is another physician suspects GCA and they can come. And I feel it's fairly fast to exclude giant cell arteries. It doesn't take too much time. And I'm always a little bit anxious to overlook any patient just by telephone and not having seen the patient. What's your approach?
We are very clear now. We think that we can actually give the probability score to patients over the telephone, and when GPs or other clinicians ring up, we actually then go through their all the criteria items for the probability score, and essentially the low probability patients we now have started not seeing in the clinic. Exactly as Christian said, in the low probability group, most often you actually do not need an ultrasound. We are seeing in the fast track clinic intermediate and high probability.
Will this be done by a nurse or by a physician?
This is done by a physician. So we haven't piloted it. I think a nurse could do it. And you have met Madeline, who works in our clinic. I mean, experienced nurse specialist like Madeline could easily do it, but it is still done by a physician.
Yeah. So how long does it take? Because this, if it takes 10 minutes to go through that, it's already quite some time.
5 minutes.
10, 15 minutes, I would have seen a patient.
It takes about 5 minutes.
Okay.
And the most important thing is that we go try and pick out the alternative diagnoses. The big problem with the diagnostic categories, all that exist, is none of them talk about the presence or absence of alternative diagnoses. And I think both with GCA and with PMR, alternative diagnoses are just as important, where you're going to be talking about it in a minute.
Absolutely, and I think that's really now a perfect, now I'm missing the term in English, but you know what I mean, so that we come now to the next topic, which will be introduced by Christina.